Good morning, Jennifer Brown. How are you?
Good morning, Jen. Happy Monday.
Yes, just another Monday in COVID. Here we are.
Here we are. Oh my goodness, the numbers just keep getting worse and worse. We're in for a tough period here, but happy to still be having these conversations with amazing, inspirational lights in the form of people like Sam McClure. So welcome.
Yeah.
Thank you. It's really such a pleasure to be here. It's funny. Sitting with the two of you sort of feels like old home week for me. I'll say we've interacted together in many formats, and it's been a while. It's been a bit of time since I went from the NGLCC over to Chase Brexton Health Care. So it's good to be in your company and your wisdom once again.
Oh. It has been a while, and Jen, we actually owe Sam credit for our friendship because it was Sam who was insistent on the two of us connecting over a decade ago. And here we are. Thank you, Sam.
We are. Oh my goodness. That's
it's my pleasure. That's what chamber leaders do. We connect great entrepreneurs together to build things that are even greater in collaboration. And I remember that thought, oh, these two belong together.
Oh, how did you know?
And then seeing you interact together over the years, always such a pleasure.
Oh,
good stuff.
Oh, such good stuff. So Sam, you have made quite a important leap in what you do. And so you just kind of prefaced with the fact that we were all connected through your work with the National Gay and Lesbian Chamber of Commerce. Even before you were with the NGLCC, you were with the Minneapolis affiliate. So, we go way, way back, but you are doing some really incredible work now in the health space around LGBTQ people. So can you just kind of start off by telling everybody kind of a broad overview of what it is that you're doing?
Yeah, absolutely. And thank you for noting how far we go back. And I will just say that neither of us have aged a bit, even though it's been that many years. Where I work now, I'm the executive director of the LGBT Health Resource Center at Chase Brexton Health Care. And how I landed here is I had this sort of passion. I call it a simmering passion because it had been in my mind for a long time, but I just kept sliding it to the back burner. And that was around LGBTQ health equity. And the topic came up a lot in my work in economic development as well. And I kept thinking, gosh, I want to do something about this. But I really never had the opportunity until I made my decision to move on from the NGLCC after a really nice long run there, one that I'm very proud of. And I saw this opportunity at Chase Brexton Health Care, and I thought, this might be a chance to explore this topic. And in fact, it was a perfect fit for that. And I was lucky enough to be considered and ultimately to get the job, which I'm sure was a bit of a wild card hire because I don't have a healthcare background, but I do have an advocacy background, and that turns out to be really valuable here. And what we do at the Resource Center is we are champions of LGBTQ health equity. Our work is very centered on training providers to be fully prepared to meet LGBTQ patients and take really good care of them. And we've found, and research validates that training for providers in both medicine and behavioral health, all healthcare, training on how to work with and understand LGBTQ people there's not much of it. I often start lectures and meetings that I have by asking providers, like, by a show of hands, how many of you have taken a course in LGBTQ healthcare? And, 4 or 5 hands will go up. I'll be like, oh, that's more than I expected. Now, keep your hand up if that session was more than a 15-minute sidebar. And then half the hands go down. And then I say, okay, keep your hand up if it was more than an hour. And then there's 1 hand left. And then I'll say, okay, now I just want to ask you something about the training. Did they talk mostly about L and G and take a very brief moment on B and skip C altogether? And they're always like, yes. And that story is why we have to develop so many training products, because the schools aren't preparing providers for what they need to take really good care of their community.
Yeah. That's such an evolution, Sam, that's so important. Can you share maybe some statistics about trans and gender non-binary health and then the disparities, and also kind of give us context about this year, because we've learned a lot of different things about disparities for health this year. COVID and a huge education about how inequitably people experience a pandemic, right, based on identity. So could you talk a little bit about the statistics, and maybe had things been exacerbated this year? But also, are there some areas where we're looking forward in terms of our understanding of different identities within the LGBTQ plus family? So give us kind of the current lay of the land.
Well, I'm going to approach your question from the lens of our particular patient population at Chase Brexton Health Care, because these are the statistics that are most relevant to me. And in some ways they align with the national landscape, and in some ways they don't. But Chase Brexton Health Care, we're federally qualified health center, which means that we have a mandate to serve medically underserved people. So among the patients that we serve are not only LGBTQ patients, where we have a center of excellence in LGBTQ health care, we also have a center of excellence in HIV care, and we also serve all patients regardless of their ability to pay. So we see all communities who are experiencing inequities in healthcare, to put it in a nutshell. And Baltimore is a very, very diverse city, and Maryland is a fairly small state. The demographics are more concentrated in Baltimore City than do extend across the state. And we serve about 40,000 total patients per year. And if you look at the patient population that are people who identify as transgender or gender nonconforming or non-binary, those patients number around 4,500. So more than 10% of our patient population, which is by percentage a very large population for a healthcare center that sees all people. If you look at LG and B data, it is a little bit harder to count.
You're still muted, Jen, if you were trying to say something.
I'm fine.
Okay, if you look at LG and B data, we all stop because everyone's been stuck on mute at least 10 times a day for, basically all of 2020. Could be the theme of 2020 could be, where in the hell is the unmute button? If you look at LG and B data for our patient populations, it gets a little bit harder to count. What we call SOGI data, that's sexual orientation and gender identity, it's wildly imperfect in the way it is collected. And in some respects, transgender, gender nonconforming, and non-binary can be easier to capture because there's more opportunities for questions. But we think those populations are probably around 1,100. So when you put all of LGBTQ together, to the best that we can collect that data, you're looking at, I think, around 6,000, which is a big patient population. And, getting back to your original question about disparities and inequities, the most common disparities for LGBTQ people are hesitancy to trust their providers. And then there's everything that kind of cascades down from that. It means that people don't get preventive screenings as often as they should. It means that they may or may not disclose important information to their provider because the environment doesn't feel welcoming. More importantly, it doesn't feel affirming. And, in order to build trust with a provider, you need all of those elements. So we see gaps in preventive care. We see higher rates of substance abuse. Certainly, risk for HIV is higher among some in the LGBTQ community, and that, I think, is changing over time as the dynamics of HIV have changed as well. And then, in terms of COVID, I think what we know to put it in as simple terms as possible, is that a pandemic puts a microscope on existing inequities. You know, the media was transfixed by the idea that communities of color were experiencing disproportionate harm due to COVID. And there was a part of me that was just like, is it possible that the disproportionate harm experienced during the pandemic is almost a mirror to the inequities in healthcare in general that no one ever looked at? My argument would be yes, it definitely is. And the same is true for LGBTQ. The best information about the disproportionate effect on this community came out of the LGBT Cancer Network. And that information was broadcast sort of broadly all over the place to try to get researchers' attention. But the same issues underpin both inequities for this community and for communities of color, Indigenous people, so forth.
I'm curious, Jenn, and actually for you, Sam, too, just thinking about the lack of comfort for people going into any type of healthcare setting, whether it's an emergency room visit or it's with your general practitioner. I'm curious if you, Jenn, have ever kind of closeted yourself intentionally in one of those settings, because I know I personally have, and that was during the time that I was doing the LGBTQ consulting work that I was doing. So I'm curious if you've ever done it as well.
Isn't that ironic? Yep. I think I probably have. Yeah, I mean, now I try not to, but I always feel like in the conversation, that's like this little leap of faith moment. And I definitely am very conscious of the discomfort of revealing that for the first time. And then I really enjoy noticing the response by the provider, right? I think that's really interesting, you know. And then I also, when I walk in, I notice signage, right? I look for rainbow flags. I look for all are welcome here. So I'm always really fascinated about the systems, like the business that's either choosing to communicate, like send me signals, you know, in sort of communications or signage, or like the forms I fill out, like whether there's gender identities reflected, right? It's not just, so, you know, I'm in New York City, so we have some incredible award-winning health systems that are extremely forward on this. And it's just so amazing to walk into that. And that therefore in the private conversation with a provider, I'm more likely, right? I then have to make a different choice if I've seen all that. So Sam, I was fascinated that you said there's a difference between welcoming and affirming. And it's subtle, but I think it's really important they're different. So anyway, that would be my answer, Jenn. And I'm curious about you too. And Sam, you know, obviously you have a lot to say about this.
I mean, you said a lot of the things I was going to say, and I'm so glad you did, because it's not theoretical when we're talking to each other as individuals. Like, I went to a doctor and I saw these things that's happened. And I have a recent experience, and I'm not going to name the doctor because I think she's an extraordinary doctor and she's taking really good care of me. And I'm going to say that I'm going to invest some time in explaining to her what happens when you use language incorrectly. Because I just recently went in for a pretty routine kind of thing, dermatological, you know, as we get older, we have to have people look at things and decide if they're just a thing or something to be concerned about, right? It's proper screening and good preventative health care. And the office was like very chic and fancy. I walked in, I was like, oh, this place is nice. And then instead of a stack of forms, they handed me an iPad, and I was like, oh, this is nice too. It's very sophisticated. And I'm going through all the demographic forms and things, and they got to where they need to collect what we call SOGI data, a collection of sexual orientation, gender identity data. And for the choices, I don't remember what all the non-LGBTQ choices were. It might have just been, I don't even remember. But the only choice for LGBTQ identity of any sort was homosexual. So as a professional working in LGBTQ health equity and teaching people language and working in advocacy for such a long time, I think I was so stunned that someone would use the word homosexual that wasn't in a conversation that was meant to harm people, because it's used very, very skillfully there by certain political forces and whatnot. Yeah. I just went ahead and checked it, and I didn't do anything. And I just made a note, I'm going to do something later because I don't want to set the tone of my appointment with, discomfort for the provider. Now, it's probably going to take a therapist to figure out why I was worried about the comfort level of the provider and my own safety, but whatever. This is what happens. This is what we experience. And I'm a professional. Like, I shouldn't have blinked at that moment. I should have just said something. But I'll go back to it later, because someone in the creation of this demographic form chose a clinical word that they don't realize is completely offensive. And now it's on me to explain it to them. And I wasn't out doing a house call as the executive director of the resource center. I was actually a person going in to have a fairly intimate medical procedure done. And that was at most unwelcoming. I mean, at the least it was unwelcoming. And yeah, it's terrible. And I think if I were to have addressed it in the moment, someone would have said, oh, well, I didn't know that. Mm-hmm. And it's like, you really ought to know that. You really ought to know that.
Yeah. And part of the reason why I wanted to even ask this question between the three of us, because we are having a conversation that for many is on a very, very high level. And so while there are probably a lot of LGBTQ plus people who are watching our conversation, or maybe we'll, replay it at a later date, there are a lot of people that probably don't even have the basic context. So I think that the three of us are looked upon as experts in different forms and fashions around the LGBTQ space broadly. And so to just humanize the three of us by acknowledging that, yeah, even though we have all either are actively doing this or have done this, we are still humans that have to put our safety before our advocacy. And I think that that's something that's just a really important thing to note.
Yeah, it really is. And, I think another simple example, and I'd be willing to bet, well, I'm not going to say how much, but I would bet a lot. I feel confident in this wager that all three of us have had at least one experience similar to the one that I just described, where something in the form you had to fill out before you went in completely dismissed that you even exist. Whether it's, question about spouse that doesn't use a gender neutral term or acknowledge that same-sex married people exist, or I'll tell you, I have a personal story that didn't happen to me, but it happened to a family I know, and it was the very first thing I ever heard that got me interested in health equity. I want to think that this child was 4 years old when this happened, 4 or 5, had a visit with the pediatrician and went in with one of his parents. He has a large queer blended family, lots of parents and grandparents. And the regular pediatrician wasn't there, and he had to see a different pediatrician. And the doctor was like collecting a bunch of information at the beginning of the visit and talking to the child, parent in the room, but talking to the child. And there was a question that they were asking about their family and their parents. And so she's asking the questions and he's answering, and he's like, well, there's mama, and then there's baba, and then all these other kind of affectionate names that he has for all of his parents and his blended family. And at some point, I think the pediatrician said, "So who's your real mom?"
Mm.
So here's this moment where a 4-year-old is like, one of my moms isn't real. Like, what does that even mean? Like, just shock moment for this child. And you know what she really meant was, who's your birth mother? Which is probably not language that he would have used. And it took so much time to get this child back in an emotional state where they could go through the visit. It was so traumatic to both the child and the one parent who was in the room. And I heard this story, and I just thought, you know, all that provider had to do was say, "Hi, tell me about your family."
Mm-hmm.
He would have told the whole beautiful, complicated, wonderful story, because he tells it all the time, every time he goes anywhere.
Mm-hmm.
But she approached the question with her own bias and preconceived notions and clinical language. And it was traumatizing and jarring to a little kid.
I'm confident that every LGBTQ parent has a story like that, because I have a litany of them. I will not get into all of them, but I got to the point where and I still will bring a Sharpie marker with me to any appointment. And when there is not the proper box or line, I will be really obnoxious about it. And I will use a Sharpie to cross out whatever it is and then write in what should be there. And I've done it since 2008. So, you know, it's one of those things that, you know, and I'm sure it's obnoxious. And there are times that I've had conversations, especially with pediatricians, to kind of acknowledge that after the appointment, and then you're at the window, like giving your insurance information and stuff. But, you know, I shouldn't have to do that. And neither should other LGBTQ parents. But here we are in this weird situation where we're putting all of this pressure on a little kid that is not necessary. And especially if you're in like an emergency type of situation, which Lord knows I've been in the emergency room more times than I can count for, you know, any number of assortment of ailments. And the emergency room seems to be the worst culprit in terms of not having proper, at least here in Connecticut. But yeah, so it's I don't know, it just seems really unfortunate. And I feel for that poor 4-year-old for having to have, defended his family and then being kind of like shook to his 4-year-old core. That's not fair for anybody, adult or child.
Right. It's really unacceptable. And I think, it gets to the heart of why we have to train providers, because it's not acceptable that the LGBTQ patient takes on the responsibility of training their doctor. And if you think it's bad, I mean, I think about my own experience as being difficult. And then I translate to what's that like for a transgender patient? Mm-hmm. Mm-hmm. Patients should not have to go to a provider and then teach them how to take care of them. That's not our responsibility as a patient. And that's why we do so much time and energy on training, because the medical provider needs to be prepared. And if their school did not take responsibility to prepare them, then it shouldn't be on the patient to do that. Medical systems have to invest in ensuring that all of their providers are fully prepared to take care of all of their patients who come from many different cultures and come in with many different identities. And that's the responsibility of the system. And what I found when I came into healthcare is that there's a shortage of resources to do this teaching. Mm-hmm. And that's why we focus so much on teaching.
Such good stuff. Jenn, any final thoughts or questions for Sam?
I don't think so. I mean, Sam, I think, emphasizes the need to self-educate. So if our institutions don't provide this, it doesn't mean we don't have a responsibility to do it. And hopefully the institution will catch up. And I think this is also where allies and accomplices, which are often the provider, right, doesn't identify that's the problem. So if we can activate allies to say one of the things you must do as an ally, somebody who's quote unquote well-meaning, put it into action and take responsibility for your own learning. Don't wait for your institution to get organized, because that typically is a lagging process. I'm also mindful that, Sam, everything you're talking about for providers is the same as managers in the workplace. Same thing. You know, when you have a new team member, when you kick off a new initiative, why do we share our pronouns? We do, especially the ally leader, because often it's not something who identifies as part of the community. Why do we share our pronouns? You know, or why do we modify our language and say, tell me about your family versus, oh, are you married? What did your husband do? Right? So there's like really subtle but huge things that can either cause a ton of damage that lasts a long time and breaks the trust and makes somebody go into the closet for years. I mean, that one choice and to know that that's a sensitive topic, or to say sexual preference instead of sexual orientation. I mean, so many well-meaning people don't understand that nuance, and it's so important. Anyway, so there's a lot of parallels, I think, in all kinds of workplaces. So those are some of the points I'd make. And the other final point is, when I walk into that medical institution and kind of notice signage, look at forms, I think to myself, there's an ERG. I wonder if there's an LGBT group advocating for change within the institution, and for big hospital systems like the Beth Israels and Mount Sinai's and everything here in New York. I know that those efforts exist, and those are grassroots employee efforts that are like, hey, let's train our institution so we do better. So I'll also always wonder, like, how did this change happen? Like, how did that sign get made? How did that physician learn what they were supposed to say? How did those forms get changed? When you do see the evidence of when it is successfully done, it's amazing to see and kind of think about, like, reverse engineer it and think about, well, I wonder how this happened. Because that's what really fascinates me. Sort of institutions are big, complex, ocean liners, and it takes a lot to kind of make these changes. It's very bureaucratic and all of that. So I do think, wherever listeners to this kind of sit in any kind of system, I guess my point is that we can all influence change, but to think about, know that it is possible to shift the experience of that person that walks in that day. But we need to be thinking through every single little, like, micro signal and macro signal and different, like, points of contact along the patient's journey. And ideally, it's not up to the patient to educate, but ideally employees are educating each other. And that's done by not just LGBTQ plus people, but allies, because allies are numerous. That is a fact. And so I think this is the work also of all of us who want a better and more equitable world.
Yeah, I think you're absolutely right. And some of the healthcare organizations that do it best are being motivated by those employee groups or great champions somewhere along the way. And it's all health equity work it's more than just the right thing to do. It's also about public health. Because if you attempt to go to a doctor and you have a bad experience where you don't feel welcomed and validated and cared for, a lot of people just don't go back. They just don't go back. And we need a relationship with a primary care provider. We all need that. We need it whether we have the financial resources to get it or not. It's just part of taking good care of ourselves. And the system needs to embrace us and welcome us and affirm who we are. And if they do that, we'll keep coming back and we'll all be healthier for it.
It's a beautiful way to end.
Yeah, thanks, Sam. That was great.
Oh, I'm so happy to see your face today, because I don't get to see it.
Right back at you.
We miss you.
Well, thanks so much for having me today. It's always a joy to talk to the two of you. So invite me back anytime.
Oh, you bet.
Thanks a lot. Okay.